Department of Health and Human Services and manages the Healthy People Initiative. Next slide, please. I'd like to welcome you to the second webinar of the Healthy People 2030 webinar series. Through this series, ODPHP, with the statistical expertise of the National Center for Health Statistics, aims to feature the latest data on the Healthy People 2030 leading health indicators, overall health and well-being measures, and the Healthy People 2030 objectives. We also plan to feature states, communities, and organizations working to achieve the Healthy People 2030 targets. You can stay informed on these webinars by joining our Healthy People listserv to learn about the dates and themes of upcoming webinars. Next slide, please. Today's webinar is titled Leveraging Healthy People 2030 to Address Issues Affecting Children, Mothers, and Families. We will first hear from Carter Blakey, the Deputy Director of the Office of Disease Prevention and Health Promotion, who will present on the importance of the 3 objectives featured in this webinar and explore how these objectives impact child and family health and well-being. Following Carter's presentation, we will hear from Dr. Irma Arispe. Dr. Arispe is the Director of the National Center for Health Statistics Division of Analysis and Epidemiology, which is responsible for monitoring the nation's progress toward healthy people targets. Dr. Arispe's presentation will provide details on current progress toward meeting objective targets for the 3 Healthy People core objectives featured today. Lastly, Barbara O'Brien, Director of the Oklahoma Perinatal Quality Improvement Collaborative, will share details on statewide efforts to reduce maternal mortality and severe maternal morbidity. We will have a moderated Q&A at the end of this webinar with these speakers, as well as several subject matter experts on the 3 featured Healthy People objectives. Thank you, Matthew Rabbit and Charlene Krollinger, for joining us. We encourage you to please submit your questions in the Q&A box throughout today's presentations. We will do our best to address as many of the questions as time allows. It's my pleasure to now transition the webinar over to Carter Blakey. Carter?
Great, thank you, Debbie, and thank you to everyone who's joining us this afternoon. So over the next few minutes, I'll give you a brief overview of the Healthy People 2030 objectives that we'll review today and talk a little bit about their public health significance. So next slide, please. So today's webinar will feature 3 core Healthy People 2030 objectives that are listed here on this slide. They are reduce non-fatal child abuse and neglect, which is injury and violence prevention objective 16, and reduce maternal deaths, which is the maternal, infant, and child health objective 4, and reduce household food insecurity and hunger, which is objective nutrition and weight status 1. So these 3 objectives are what we call in Healthy People 2030 core objectives, which means that they will be tracked throughout the decade and progress toward achieving their targets will be updated as data from their specific data sources become available. Then included on the right-hand side of your slide are a few more additional characteristics of core objectives, and in short, they're measurable objectives that are associated with targets, and they reflect high priority public health issues, and they're associated with evidence-based interventions. They have valid, reliable, nationally representative data, including baseline data no older than 2015, and we're promised at least 3 data points throughout the decade. These 2 of the 3 objectives that we'll be looking at today have also been identified as what we call leading health indicators, which are a small subset of high priority healthy people objectives that were selected because they can have tremendous potential to show improvement in particular critical health issues. So next slide, please. So before we begin discussing today's featured objectives, I think we all recognize that we must acknowledge COVID-19. So the COVID-19 pandemic has affected almost every part of our lives, and it's important to recognize those impacts on the Healthy People 2030 objectives as we're reviewing them today, as well as the objectives for across the whole decade. So the pandemic has impacted measurement and data collection efforts for data sources, including national databases utilized by Healthy People 2030. It's also influenced the overall health trends in the US and many other issues. So Dr. Arespi will talk more about this in her presentation and more about the implications that the COVID-19 pandemic has had on the progress that will be observed in the objectives. So next slide, please. So every year in the United States, many children are abused or neglected, and this often causes long-term physical, behavioral, and mental health problems. So child abuse and neglect are preventable, but unfortunately, in 2020, some 1,750 children died because of abuse and neglect in the United States. So we know that experiencing poverty can place a lot of stress on families, which may increase the risk for child abuse and neglect. That rates of child abuse and neglect are 5 times higher for children and families with low socioeconomic status. And exploring and understanding the root causes of this issue are critical to addressing child abuse and neglect. And understanding the impact of the social determinants of health, like economic stability, can help us identify strategies to protect children from abuse and neglect. So that Healthy People Objective IVP 16 tracks non-fatal child abuse and neglect. And Dr. Arespi will provide progress to date on this objective in just a few minutes. So next slide, please. So another important issue that we'll cover today is related to maternal health. So women in the United States are more likely to die from childbirth or pregnancy-related causes than women living in other developed countries. So when looking at maternal mortality data, so we observe considerable racial and ethnic disparities, and rates for non-Hispanic Black women are 3 to 4 times higher than for non-Hispanic white women. So maternal mortality, which has been included in Healthy People since 1990, is an important indicator of population health and the quality of health care. So this slide underscores the need to act on this Healthy People objective to reduce more maternal deaths. And then Ms. O'Brien from the Oklahoma Perinatal Quality Improvement Collaborative will provide details on state actions to address the important issue of maternal deaths. So next slide, please. So household food insecurity is defined as having difficulty at some time during the year providing enough food for all household members because of lack of resources. So food security is necessary for a population to be healthy and well nourished. And research has shown that food insecurity is linked to negative health, development, and education outcomes. And there are a few details elaborated on in the slide here. So then looking across the lifespan, research has shown that adults in food insecure households are more likely to report having a chronic disease, and children in food insecure households are likely to have poorer health. So food insecurity may be influenced by a number of factors, including income, employment, race, ethnicity, and disability. So the risk for food insecurity increases when money to buy food is limited or not available at all. Dr. Arespi will highlight the population level differences for this objective, and such disaggregated data helps us identify populations that may be further away from the Healthy People 2030 national target and alert us to their special needs for additional resources. So next slide, please. Great. So Healthy People recognizes the impact and influence that the social determinants of health have on health, functioning, and quality of life outcomes and risks. So the social determinants of health have been a central component of Healthy People for decades now. So the framework featured on the slide here is the place-based framework developed by and used by the Healthy People Initiative. So it can be leveraged to identify how to create equal opportunities for all people to achieve the highest level of health and well-being possible. And then when reviewing our objectives today, it's important to recognize the influence the social determinants of health have on populations and the nation in reaching the Healthy People target. So for example, food security may be influenced by a number of factors, including income, employment, and food insecurity can influence health, including increasing risk for obesity. So food assistance programs such as the National School Lunch Program, the Women's, Infant, and Children's Program, and the Supplemental Nutrition Assistance Program address barriers to accessing food, healthy food choices. So, as we continue to work on these objectives that we'll talk about today, we really must consider all the determinants that may prevent populations from moving toward the Healthy People targets, and of course, achieving health equity and health and well-being for all. And it's also important to acknowledge that COVID-19 has influenced all of the social determinants that are laid out on this slide here. So as the nation emerges from the COVID-19 pandemic, so we look to Healthy People 2030 as an initiative that can provide a foundation on which to frame an approach for recovery that results in a more equitable and resilient state than existed before the pandemic. So HHS has recently released several plans to address inequities, the social determinants of health, and build a resilient and healthier nation. So this includes the HHS Health Equity Plan and the HHS Social Determinants of Health Action Plan, which aims to make health outcomes more equitable by coordinating health and human services and by adopting a whole of government multi-sector strategy to address the underlying systemic environmental factors that affect health status. So to make progress on all of the objectives that we're talking about today and all of them in Healthy People 2030 as a whole, and to actually achieve our vision of a society in which all people can achieve their full potential for health and well-being across the lifespan, we need to take collaborative action nationwide. It's only by working together across sectors to address important Healthy People objectives, such as the ones we're discussing today, that we can strengthen the health of our children, mothers, and families. So with that intro, I would like to turn the meeting over to Dr. Arespe to give an update on progress to date on these three objectives. So Irma, it is all yours.
Thank you, Carter, and good afternoon, everyone. Could I have the next slide, please? I'm pleased to be here with you today to share data for the three important Healthy People 2030 objectives chosen to frame our discussion on children, mothers, and families. Two of the measures, the one on maternal mortality and another on household food insecurity, are leading health indicators, commonly referred to as LHIs. As we review the data, we'll begin to get a sense of the early impact the COVID pandemic may have had on health outcomes, as well as on measurement and data collection. Next slide. I'll begin by discussing child abuse and neglect. May I have the next slide, please? Child abuse is defined as any act or failure to act that results in serious harm or presents a risk of serious harm. We track child abuse using data from the National Child Abuse and Neglect Data System. And this is a voluntary data system of case-level data collected by the states, the District of Columbia, and Puerto Rico on children who receive a Child Protective Services investigation. Next slide. Historically, school and law enforcement personnel have been the two largest categories of reporters of child abuse. For instance, in the first 2 quarters directly preceding the beginning of the pandemic, about a quarter of child abuse reports originated from school personnel. With many schools moving to virtual learning in early 2020, it became challenging for school staff to observe and report suspected cases of abuse and neglect. Child abuse reports made by school personnel decreased 58.4% from April through June 2020. Next slide, please. Now let's look at the data, and we'll start by focusing on child abuse by age group. From 2008 to 2020, young children aged 0 to 4 had the highest rates of reported child abuse and neglect, while the rate was lowest among adolescents aged 12 to 17 years. At the Healthy People 2030 baseline period, which is indicated by the asterisk in the bottom left-hand corner of the slide, and in 2020, the rate of child abuse among children aged 0 to 4 was more than twice that for adolescents aged 12 to 17 years. Next slide. This next slide shows child abuse data by sex, race, ethnicity, and geographic location. The rate of abuse and neglect was about 12% higher for girls than for boys, 8.9 compared to 7.9 victims per 1,000 children. Throughout my presentation, when discussing race and ethnicity, we'll look at Hispanic ethnicity along with the racial groups, all of which exclude persons of Hispanic origin. The rates of child abuse for American Indian or Alaska Native and Black children were more than 9 times and more than 8 times, respectively, the rate for Asian children. Last, the rate of abuse was more than 50% higher among children living in non-metropolitan areas compared with those living in metropolitan areas. Next slide. Now I'd like to turn to a topic that has received a lot of attention recently, maternal mortality. Next slide. A maternal mortality objective has been included in Healthy People since the inaugural 1990 initiative, and as I mentioned earlier, has been identified as an LHI for Healthy People 2030. Maternal deaths are pregnancy-related deaths that occur while a woman is pregnant or within 42 days of the termination of pregnancy, and we track this with data from the National Vital Statistics System. External causes of death, such as accidents, homicide, and suicide, are excluded from these calculations. NCHS did not publish maternal mortality data for the period from 2008 through 2017 due to data quality issues. However, once the issues were resolved, we began publishing statistics again, beginning with the 2018 data. However, because of the differences in methodology, data from the years that are prior to 2018 are not comparable with the data that we'll be looking at today. Next slide. In 2020, 861 women were identified as having died of maternal causes in the United States. This translates to a rate of 23.8 deaths per 100,000 live births. The rate increased in 2019 and 2020, with the 2020 rate being 37% higher than the 2018 baseline. The maternal mortality rate for Black women in 2020 was 55.3 per 100,000 live births. This is more than 4 times the rate experienced by Asian women and 2.5 times the rate for white women. The slide also shows maternal mortality rates for American Indian and Native Hawaiian populations. They're displayed in lighter shaded hash bars on the right because they're statistically unreliable for each year due to the small numbers of deaths. However, we included them in the slide to provide a glimpse of the possible impact maternal mortality has had in these communities. Next slide. In this slide, we'll take a closer look at maternal mortality rates in 2020. The orange bars show that maternal mortality generally increases with advancing age. The maternal mortality rate for mothers ages 35 and over is more than 3.5 times the rate for mothers aged 20 to 24 years. The green bars, moving to the green bars, we see that there is an inverse relationship between education and maternal mortality, with the rate for those who did not complete high school being nearly 3 times the rate for those with at least a college degree. Finally, the blue bars show that the rate for mothers who lived in non-metropolitan areas was 37% higher than the rate observed for mothers who lived in urbanized or metropolitan areas. Next slide. In this next slide, we see our baseline data for the United States displayed with data for 9 other wealthy industrialized countries. As you can see, the US ranks last by a wide margin. The country with the next highest rate was South Korea, with 11 maternal deaths per 100,000 live births. To put this slide into context, if you recall, I presented a slide with data by race a few moments ago. Even if you limited the international comparisons to US rates for the racial ethnic groups with the best rates, that is Asian, white, and Hispanic mothers, the United States would still have higher maternal mortality rates than South Korea. Next slide, please. With that, let's turn to food insecurity and to families and households. Next slide. Food insecure households are defined as those that had difficulty at some time during the year providing enough food for all their members because of a lack of resources. We track food insecurity using data from the current population survey food security supplement. Since Healthy People 2010, the target has been to reduce household food insecurity to 6%. This target was selected to align with the United States Action Plan on Food Security, adopted as part of the United States response to the 1990 World Food Summit, and called for a 50% reduction from the 1995 prevalence. Remember, this objective has also been identified as an LHI in Healthy People 2030. Next slide. This slide shows trends in household food insecurity between 2008 and 2020. For the total population, across Healthy People 2020 and Healthy People 2030 tracking periods for the total population and by family composition. For the total population, food insecurity peaked at 14.9% in 2011 and then subsequently declined each year until leveling off at 10.5% in 2020. In the chart, we see that the food insecurity rate was above the national average for households with children and below the national average for households with older adults. While food insecurity for the total population was unchanged, the rate increased for households with children from 13.6% in 2019 to 14.8% in 2020. The increase among children may be due to the pandemic, but at this point there's insufficient scientific evidence or studies to make these conclusive statements. Next slide. Food insecurity was strongly associated with income. In 2020, the proportion of households that were food insecure decreased with increasing family income. The rate was more than 24 times as high for households with incomes below the poverty threshold compared to households with income that was 400% or more of the poverty threshold. The rates of food insecurity for Black and Native Hawaiian and other Pacific Islander households were more than 4.5 times the rate for Asian households. Next slide. Compared to married couple households, the rate of food insecurity was more than twice as high for households with a never married reference person, 14.8%, and twice as high for households with a divorced, separated, or widowed reference person. Looking further at the chart, compared to their counterparts, food insecurity was more than twice as high among households with one or more adults with disabilities. Food insecurity was 76.6% higher among those with a non-veteran household reference person and 12% higher among households in non-metropolitan areas. Next slide. So I'll end by sharing some key takeaways. Next slide. In summary, child abuse and neglect reporting was substantially affected by the pandemic. School closures during COVID lockdowns impeded the observation and reporting of child abuse by educators, which resulted in lower than expected reports of child abuse by education personnel. Maternal mortality in the United States is increasing and is higher than rates in other industrialized countries. Although food insecurity remained unchanged for all households between 2019 and 2020, it increased for households with children. And disparities were observed for all three of the objectives reviewed, especially for household food insecurity when we looked at income. Next slide. Finally, I'd like to thank and acknowledge the three work groups whose objectives were highlighted today, the data programmers and the NCHS staff listed here for their contributions. Now I'll turn it over to Barbara. Thank you very much.
Thank you so much. And I'm very thankful to be here this afternoon to present on the work of state perinatal quality collaboratives to reduce maternal mortality and severe maternal morbidity. I will focus on the work we are doing in Oklahoma. Next slide, please. Historically, state perinatal quality collaboratives have worked with perinatal clinicians and birthing hospitals to facilitate quality improvement initiatives to reduce infant and maternal morbidity and mortality. California has been the leading state in this work, and Oklahoma formally established the Oklahoma Perinatal Quality Improvement Collaborative in 2014. There are 41 states currently with active PQCs, 13 of those with CDC funding. 9 are with a PQC in development. The National Network of Perinatal Quality Collaboratives, which is housed within the CDC, is the group that supports the work of PQCs and assists the collaboration among the states. OPQIC is primarily funded through HRSA, through the State Maternal Health Innovation Program Cooperative Agreement, and through Title V Maternal Child Health Funds. Next slide, please. Our vision is a culture of excellence, safety, and equity in perinatal care. The next slide, I want to provide you some context of maternal and infant health in Oklahoma. We currently have 46 birthing hospitals, with 58% of those located in a rural location and 42% in an urban area. In Oklahoma, we have approximately 47,000 annual births, with 69% of those births occurring in urban hospitals and 31% in rural hospitals. These hospitals have from 2,500 to 4,400 annual births. About 51% of our births in Oklahoma are covered by Medicaid. And in Oklahoma, we have 7 level 3 or 4 neonatal intensive care units, and they are all located in the metro areas of Oklahoma City and Tulsa. Next slide, please. This is a map of the birthing hospitals in Oklahoma currently. We have 77 counties in Oklahoma. 27 include a birthing hospital. 50 then are without a birthing hospital. To provide maternity care services, hospitals need very specific resources, and these resources can cost quite a bit of money. So we have seen a decrease in our birthing hospitals in Oklahoma, particularly over the last decade, and that has been also happening nationwide. Next slide. This is a screenshot of our website, so you can go to our website to learn more and find out more information about the work that we do within the OPQIC. Next slide. I want to highlight some work that we have done to reduce maternal mortality and severe maternal morbidity. The Alliance for Innovation on Maternal Health was launched in 2015. This is supported through a cooperative agreement with HRSA and the American College of Obstetricians and Gynecologists. Oklahoma was the first state to join AIM in 2015. And we are focusing on the obstetric. We've began with our focus on the obstetric hemorrhage and preeclampsia and severe hypertension maternal safety bundle implementation in our birthing hospitals. Next slide. These bundles are developed by subject matter experts and within the Council on Patient Safety and Women's Healthcare. And then the Alliance for Innovation on Maternal Health is the implementation arm. The Alliance for Innovation on Maternal Health provides resources for the states to use, usually through their state perinatal quality collaborative, to work with the birthing hospitals so that these hospitals don't have to create these initiative on their own. They can use these resources. The hospitals work and collaborate with each other, and the states collaborate with each other as well. One of the key resources that AIM provides is a data portal so that we can guide our work of quality improvement through data. And these data that we measure include outcome, process, and structure measures that the hospital will enter. And so the hospitals and the state uses these data to inform our work. Moving to the next slide, these patient safety bundles are supported by specific quality metrics through the AIM Data Center, which I mentioned. And they are the core building blocks of the efforts to address the leading known causes of preventable severe maternal morbidity and mortality in the United States. Those data are achieved through the maternal mortality review committees in each state. Each bundle were developed as part of the Alliance for Innovation on Maternal Health, which, as I mentioned, is funded by HRSA. These are the primary safety bundles listed here. And as I mentioned, Oklahoma first focused on the obstetric hemorrhage and the severe hypertension in pregnancy bundles. With these bundles, it ensures that birthing hospitals are ready, and they are ready to address these issues. They recognize when they occur, they respond with a standardized response, and that they report and include data. And then also to ensure that this, the care that is given is respectful for the birthing family. If you'll move to the next slide, I want to show you some results, and these are associated, the time period of these results are associated with the implementation of the hemorrhage and hypertension maternal safety bundles in Oklahoma. The next slide shows Oklahoma-specific data for maternal mortality. You heard in the previous presentation about the U.S. data. These data are obtained through the Maternal Mortality Review Committee and their Oklahoma Vital Records. You can see that we started seeing a decrease in the maternal mortality rate after the implementation of these bundles. I am sorry to say, though, that we know that these rates will likely increase beginning in 2020 and particularly in 2021 because maternal death rate have increased due to COVID-19. Pregnancy is makes a person especially vulnerable to become severely ill with COVID-19 and experience death. In Oklahoma, we have not reviewed those cases yet through our Maternal Mortality Review Committee, but we do know that we have had increased deaths in Oklahoma related to COVID-19. In Oklahoma, we also have similar disparities as were mentioned prior. We do also collect those data. Looking at our next slide, it is challenging for a state like Oklahoma to use data to guide change that is rapid cycle improvement because maternal deaths are so few in number. In Oklahoma, we have about 15 to 20 maternal deaths per year. So we use a proxy measure of severe maternal morbidity. This is what's used through AIM, and it is data, hospital discharge data that has been published by the CDC. And this, loosely defined, is a person who is admitted to the ICU and or receives 4 units or more of blood during the birth hospitalization. So you can see in Oklahoma, we have seen a decrease in the severe maternal mortality rate in Oklahoma. These are percentages, and particularly in that time frame where we have been implementing the hypertension and hemorrhage safety bundles. Unfortunately, we did see an increase there at the end from in 2020. But you can see when you look at the number of women, this decrease was almost half. But our rate comparing the average points prior to the red line to after the red line when we began the AIM bundle implementation, we have seen a 22% decrease in severe maternal morbidity. Looking at our next slide, I'll describe some current initiatives that we are also doing in Oklahoma. The first one I will describe as the Empowering Pregnant and Postpartum Patients. One of our core values at the Oklahoma Perinatal Quality Improvement Collaborative is to elevate and include the voice of patients in all of the work that we do. We are the first state to include a patient on our staff. So we have a full-time patient partner on our staff at OPQIC. And part of the work that Sarah does is work with other people across Oklahoma who have experienced severe maternal morbidity and or families of those who have lost a loved one related to childbirth. So this program that I'm going to describe, we are piloting right now in a few hospitals, and it is a toolkit that we have used to ensure that pregnant people and families and really the entire community is aware of warning signs during pregnancy and in the postpartum period, and also is aware of how to seek help and are encouraged to seek help if they experience any of these warning signs. And also another 2 items I'll describe too. If you look at the next slide, the first 2 components of this toolkit are related to those warning signs. One of the things that maternal mortality review committees discover is that patients may not seek help when they experience warning signs, particularly in the postpartum period. People might say, well, you're tired, or dismiss concerns. So we want to ensure that patients are educated during the prenatal care period and the postpartum period, and also their families are educated, and we are also working on educating the entire community. With this, providers need to ensure that they listen and they investigate concerns when families present with these warning signs. Looking at the next slide, the first 2 addressed urgent and emergent issues. These next 2 components of our toolkit are related to a helpful post-birth resources that our patient partner network created. And number 4, I'll show you the helpful post-birth resources on the next slide. But the 4th component is ensuring that every pregnant patient upon discharge at the birth hospitalization receives education on of a clinical summary about her birth circumstances, so that she has this on a written form and is educated, and her family understands what happened when she gave birth, so that particularly if she needs to go to another hospital, that they would have an understanding of what took place during this woman's birth experience. The next slide has an overview of the helpful post-birth resources information we give, including breastfeeding support. The New Mom Health and Family Support is for postpartum families and pregnant families. Mental health support through Postpartum Support International, and a patient-facing page on our website as some credible and validated post-birth resources. The next slide shows our web page with these patient-facing pages that our patient partner network has created. Next slide, let me talk a little bit about a couple of other initiatives that we are also working on. The next slide, I want to mention the Oklahoma Mothers and Newborns Affected by Opioids. This was launched in 2020, right before the pandemic. So we had to reboot, pause, and then reboot. And we have cohort 2 of this initiative beginning in 2022. And this ensures a comprehensive approach to pregnancy and postpartum care and infant care for those pregnant people with substance use disorder or who practice substance misuse, and to ensure their infants also receive appropriate care. And then the last initiative I'll describe is looking at our next slide is Team Birth. We are doing this in a partnership with Ariadne Labs through the State Maternal Health Innovation Program funding. And this is to ensure that all families receive safe and dignified care during their birth, focusing on a structured communication model that is visualized with a shared communication planning board, and ensuring that important decisions are made with the mother's team and the hospital team together in the room or via speakerphone, so that these huddles occur and everyone can understand what the preferences are of the patient, that they are valued, and then everyone understands the plan of care for the mother and the infant. We're launching cohort 2 of Team Birth currently, and we are the first state to launch Team Birth statewide. Looking at the next slide, I just want to mention briefly how these relate to Healthy People 2030. Of course, the reducing maternal deaths that we talked about with the safety bundles can improve the quality of care during the birth hospitalization, and ensuring that people seek help when they are experiencing warning signs is also impactful. And then the standardized care and using Team Birth by elevating the patient voice and enhancing dignity and respect. Our goal is to reduce some of those disparities. The next goal on the next slide, with non-fatal child abuse and neglect, with the Care for Pregnant and Postpartum People with Substance Disorder bundle implementation through OMNO, we can ensure that these families receive the support and the treatment needed. So hopefully, when appropriate, families can stay unified during pregnancy and postpartum and infancy. Finally, just some lessons that we have learned. If you go to the next slide, that this state PQC model is successful at the state and the national level. We have a mantra of just say yes, that we will participate in these things. We use this rapid cycle data driven improvement model. We celebrate wins often and recognize all of our champions. And we have multiple partnerships that we work with who can influence at many levels. We're moving into non-traditional partners to address those social determinants of health that impact care more outside of the birth hospitalization. And then we also, as I mentioned, value patients and families at all levels. And the last slide, just with my contact information and how you can follow the OPQIC. I will now turn it over to Carter Blakey.
Great. Thank you, Barbara and Irma, for your presentations. They're both fascinating, and I'm sure we could spend a lot more time digging into the details of both. But we do have a couple of questions. So, Barbara, I think I'll start with you, and Charlene, you might want to weigh in as well. So, talking about collaboration across, let's say, geographic areas. So, how do perinatal quality collaboratives coordinate their work across states and regions? So, Barbara, is Oklahoma involved in coordinating across states and regions?
Yeah, so through the National Network of Perinatal Quality Collaboratives, that is a group where we learn from each other. We have monthly webinars and also meetings, and we have a listserv so we can learn from other states and what they're doing. This is housed, as I mentioned, within the CDC, and there will be, CDC provides funding to state perinatal quality collaboratives. That will be changing soon. We'll know who the states that are funded in August. I believe there will be 22 this time, where there are now 13. And that can also help us work together. And the other body is really through the Alliance on Innovation in Maternal Health, or AIM, so that we work together through these implementation of these safety bundles.
Great, thanks. And then Charlene, does CDC have any plans to kind of facilitate increased collaboration or grow it in any way? Barbara just said that you're adding more of the collaboratives. So.
Yes, great question. And thanks, Barbara, for that answer. Yes, we are planning to grow the Perinatal Quality Collaborative programs through funding additional PQCs in the next year. And we're also growing the National Network of Perinatal Quality Collaboratives that Barbara mentioned, which is the organization that shares best clinical practices, coordinates quality improvement initiatives, and touts successes.
Great, thank you. And I see a question that I think someone might be able to answer in the chat about whether or not slides will be made available. And I think the answer to that is yes. I think they're available for download, but I think someone else might be able to answer that more accurately. So Matthew, thank you so much for joining us from USDA. We really appreciate having you with us today, and especially since this webinar is hosted by the Department of Health and Human Services. I think it demonstrates the importance of working across sectors, and we do work very closely with USDA in all things nutrition and food related. But here's a question for you. What are some potential causes or factors explaining the increase in food insecurity among children in 2020?
Hello, and thank you for inviting me here today. There's really several factors that could be occurring that could be leading to a rise in food insecurity among households with children between 2019 and 2020. As we all know, with the onset of the pandemic, there was a large upheaval in the economic activity of various states throughout the United States. And so That led to changes in the employability of individuals. So there are many households with children that either did not have flexible work arrangements that could potentially lead to them having to quit their jobs or work less, which means they're bringing in less household resources, which can be used for food, and that could be potentially leading to increases in food insecurity. In addition, as we all know, that there was a large change in the food environment of resources available to households with children during the pandemic as a result of the unprecedented scale of closure of schools, which led to a reduction in the amount of food being provided to children through school feeding programs such as the National School Lunch Program. And so this led to less food resources for at least a short period of time before new programs were put in place or adjusted that could have potentially also led to increases in food insecurity among households with children. Another potential reason is the rise in food prices, leading to generally an increased cost in the amount of food that the food basket can be afforded by households with children.
Great, thank you. And that's a great answer, and actually might help answer a question that came up around mitigating some of the social determinants around health, around poverty. And I think those programs that you talked about are perhaps a step in the right direction. And then related to that, Barbara, you mentioned I think in one of your closing slides about the importance of working across sectors to make a difference in the area of maternal deaths and the child abuse and neglect objectives. So what are some examples that you're using, that you're putting into place, where you're deliberately working across sectors, especially sectors that people might not think of as being related to these health issues?
Yes, so as I mentioned, traditionally PQCs have worked, their work focuses on birthing hospitals. But we know that a lot of determinants of health impact outcomes that are outside of the birth hospitalization. So these social determinants of health are very important for us as state PQCs to look at. And that is one of the things in our application for a CDC funding grant we will focus on if we are an awardee, to have a community excuse me, a staff member who focuses on working with community organizations and ensuring that patients have the resources that they need. So that's one of the things we see, is that many times that providers may be unaware of resources, and so that the families do not get connected to them. Particularly, for example, with medication-assisted treatment for opioid use disorder. So those are things we're trying to impact, and using non-traditional groups such as churches and the YWCA, some of our centers for those who are experiencing domestic violence, so that if they have pregnant people that present to them, they are also provided resources. So we're trying to look to see, where do pregnant people, what contact do they have within the community, and how can we use those points of contact to ensure that they are provided with the resources that they need, and also make it easy for them to use those resources so they'll be more likely to engage in them. So we are moving outside of just what happens during the birth hospitalization to look at what happens before, during the prenatal period, and after, during the postpartum period.
Great, thank you. And a question that looks somewhat related, and I think perhaps Charlene or Barbara, or even like Matthew, you might be able to weigh in on this. So how do states talk to each other so when let's say San Francisco, California, for example, is seeing patients migrating from states, and so this person would like to get thoughts on how to connect states to learn from one another. Do you have to be part of this collaborative to have access to the information? Are there other helpful resources?
Well, the PQCs generally use really what the National Network of Perinatal Quality Collaboratives does is create that network so that we have ways to work with each other. And we know who the people are in the other states so that we can contact them directly. We hear what other states are doing, and then we find out from them, hey, can you help us? Or we know to go to their websites and find resources. We share freely among each other, which is something, it truly is a collaborative environment with the NMPQC and with AIM that the state PQCs and the providers and clinicians and patients, all of their partners share freely with each other. And so it's not a formal, like the NMPQC, it is for the PQCs, but it's very easy to become a part of it. And I think that work has really increased over the last 5 years, particularly, that we have worked a lot more together and did this particularly, I'll mention, with COVID-19 and providing information on that to other states. So those generally are our methods of communication and collaboration.
Right. And Charlotte, kind of going back to COVID-19, so what are some of the specific actions or solutions that you undertook with your programs at CDC to address the challenges that COVID-19 has presented?
Thanks so much for that question. In particular, for Perinatal Quality Collaboratives, we supplementally funded 9 perinatal quality collaboratives to support vaccine confidence, equitable access to care, and vaccine administration among patients. And for this particular project, quality improvement strategies that PQCs could select included increasing provider capacity to improve vaccine confidence and vaccination, increasing implementation of protocols to screen and vaccinate in delivery hospitals, and increasing the clinical community linkages for pregnant and postpartum people to ensure follow-up. That's one great example that Barbara also gave. Best practices and lessons learned will be shared broadly across the country by the NMPQC, and is always available on their website.
Great, great. And then Matt, I think we have, Matthew, what time for maybe one more question, and I'm going to throw it out to you. So looking at food insecurity across the United States, is there a lot of variation by state? And if there is, what are some possible reasons for those differences?
Yeah, so as you might expect, there is a significant amount of variation in food insecurity prevalence rates across the United States. For example, in the most recent USDA food security report, we found that the prevalence of food insecurity ranged from 5.7% in New Hampshire to 15.3% in Mississippi. And there's really 2 main factors of characteristics that can to attribute to these differences across states in food insecurity rates. And they are drawn from the characteristics of the residents within the state, and then the state's economic and policy factors. And so at the household level, this can mean how income is distributed across the state. So maybe the state has a lower average income per individual than compared to a higher income state, and that makes them a slightly higher risk of food insecurity. In addition, educational attainment across individuals in the state can matter. And then at the state level, it can be things related to economic activity related to average wages or the unemployment rate. in addition to the general state level participation rates in food and nutrition assistance programs and the cost of housing.
Great, thank you so much. And that actually brings us right to the top of the hour. So again, thank you to our presenters and Matthew and Charlene for you joining us to help us answer some of the questions. So this concludes our second webinar in the Healthy People 2030 webinar series. And as you leave the webinar, there will be a survey that pops up. So if you would take a few minutes to answer, that would be great, because that'll help us fine tune our further webinars. So again, a huge thank you to everyone, and stay safe and stay well.